in my presentation on progressive MS, we went on deeper into the risk of smoldering disease behind the closed blood-brain barrier, which is the case in progressive MS, and that slowly handicap is increasing in these patients. While what we want to do is to intervene very early on, because later on, for now, there are no real good drugs available. So it's a question of trying to prevent secondary progressive multiple sclerosis. Now, there are new techniques and new ways of trying to detect progression in the clinic as early as possible. This, of course, via more clinical things. The clinical things, I guess, are having good tests, trying to test your patients clinically every 6 months, for example. But also more and more patient-reported outcomes are used by things that are used by your smartphone, how much paces you take a day, or from these apps that you can tap on, and then you can see the function of your upper limbs. So that gives you a lot of more granularity over time. Apart from clinical things, there are also technical ways to try and look at disease progression. For example, MRI are new techniques where we want to highlight the smoldering lesions itself. They have a magnetic, an iron rim around the lesion. When you see this on a specific scan, then you might interpret this as a smoldering active chronic lesion. And we know that that is one of the main pathological features in progressive MS. Also, brain atrophy has been very difficult to use it individually. By looking more at regions within the brain, for example, the thalamic atrophy, maybe this is more better to use at an individual level. So there are some new reports on correlating thalamic atrophy with disability progression. Biomarkers are also there, like neurofilament light, of course, that will also be there. This is a technique that is already validated technically, but there are still studies ongoing to really see how to use that in clinical practice, but is very promising. Also, electrophysiology, I believe, is a very good technique. The nice thing about that is it's a functional technique. Sometimes you see lesions or you don't see lesions, but then you want to know the function, the measurement of these nerves. And this is what electrophysiology is able to do. And there are studies that show over time that, for example, motor evoked potentials or somatosensory evoked potentials are changing over time, and that this changes is significant at certain time point before the patient feels this as a handicap. So at that time point, you know that something's going on, you can act on that. And also maybe a last measurement to mention is optical coherence tomography, which is OCT for short, which is a measurement of your retinal nerve fiber layer. The thickness of that is measured. And we know from prognosis studies that if you have a very thin retinal nerve fiber layer, that you have a bad prognosis. But also over time, every change of loss of volume of that layer has to do with loss of brain volume. It's correlation, and then this ends up in more disability. So that's also something I believe that will be more usable on an individual level to follow up patients than, for example, global brain atrophy, which has a lot of fluctuations in it. So I mainly presented a lot of views and techniques on how to early on tackle a progression of the disease at the subclinical level, where you know that the patient is losing brain reserve, and at that time point, it's still hopefully possible to stop that and to stop evolution to real clinical secondary progressive MS.